Yes, good morning, ladies and gentlemen. In order to be on the time limit, I would like to ask you to take your seats, please. Okay, it's a great pleasure on behalf of Jan de Meissner, the chair of the expert panel on health, to welcome you here for the hearing on task shifting in healthcare systems. My name is Aleš Borek. I'm one of the panel members. On my right hand, it's Dione Kringos. She's also a panel member, Luigi Siciliani. And then we have, for presenting the draft of the opinion, Martin McKee, who was also a rapporteur on this. The last member of the expert panel is somewhere within you, and it's Lyubove Muraskiene. So that's on part of the expert panel. Some housekeeping remarks. As you can see, there are several big lenses around, so this hearing is being video streamed to YouTube. You may also access it later time for referencing if you need to reference. When you will be speaking during the discussions, please bear in mind that you have to speak using the microphone, and it will be nice if you can always introduce yourself and also let know what is your affiliation, what bodies you represent, so that we will be able to work your comments and your views into the draft of the opinion before it is finalized. The essential reason why we meet here for the hearings is that even though the expert panel has 14 members and is strongly backed up by knowledgeable people at the DJ Sanko Commission part, the Sante Commission part, sorry, I'm still thinking the old way. There are certain limitations because we don't know points of view from other communities, and that is the essence of this meeting. After this short introduction, I will just tell you the timeline because the timeline has changed a little bit. The presentation of the opinion will last roughly about 20 to 25 minutes, so it has been shortened. So that will be from 11:15 to roughly 11:40. Then we will have a short coffee break where you can discuss some of the issues among yourself before we start the 12:00 to 13:15, the discussion of the participants' views. And we will have ample time for conclusions and next steps, roughly from 1:15 to 1:30 before we end this meeting. So much for the organization, and I give word to Martin McKee, who will be so kind and present consistently what has been done in the draft opinion until now.
Well, good morning, everyone. And my task is to present this opinion on task shifting in health system design. A bit of background. I found this particularly interesting because when I was a junior doctor, it was quite clear to me that many of the things that I was doing really were not appropriate for me to be doing. And in fact, some of them weren't appropriate to be done by anybody. So having been through all of that experience, this was a good opportunity to put all of this together. And actually, my doctoral thesis many years ago was on the work of junior doctors out of hours at night time, which is a challenge in many places. So let me just first introduce you again to the expert panel. Alice has already introduced you to the members here. And this is a panel that has been established by DG Sante. We are independent scientists. Our views do not necessarily reflect those of the Commission. And we have a task of providing independent but non-binding advice on effective ways of investing in health. And here's the full membership of the working group. I'd also like to pay tribute to Matthias Wismar from the European Observatory and May van Skulvik, who was is an Erasmus scholar working with me at the London School. The task that we were given was to identify and characterize tasks. suitable for task shifting process, and then to understand what the main enabling conditions and difficulties and risks are that have to be taken into account when defining task shifting measures as part of health system reforms, and then the more challenging bit, to measure the impact of task shifting in contributing to the effectiveness of a health system. So we started off inevitably by looking for a definition. Always good to know what you're talking about, and we found the WHO definition. The rational redistribution of tasks among health workforce teams, that's so within the health workforce. Specific tasks are moved where appropriate from highly qualified health workers to health workers who have fewer qualifications in order to make more efficient use of the available human resources for health. Well, that's all very good, but that really doesn't capture anything like the spectrum of activity that we saw as being involved in task shifting, because it ignores the fact that there are some things that are being done by people who are not adequately experienced and would need to be shifted to people who have a higher level of skills to do them better. We have copious evidence, for example. I'm just back from Washington yesterday, and I was at the 30th anniversary of the University of Pennsylvania's nursing research program, their Center for Health Outcomes, where they've done a huge amount of work showing that unregistered nurses, nursing assistants, don't actually get as good results as registered nurses. People die at a much higher rate. So there are some things which need to be done by people who've got more qualifications. And then in the world that we live in, there are many things that can be done by patients and their carers. And increasingly, we're seeing the expanded role of technology, machines doing things that humans might once have done. Few of you these days go to a travel agent, you do things online. And similarly with banking and so on, so why not in healthcare? So we wanted to expand this a bit and to include task distribution, where we wanted to work out, we wanted to understand who does what, to find out what is actually happening at the minute. Because one of the challenges that we have is that if you look across Europe, there's enormous diversity in what doctors do, what nurses do, what other professional groups do. Some medical specialties exist in some countries, they don't exist in others. There are some things which are done routinely by nurses in some countries and would be only done by doctors in others, and so on and so forth. And we wanted to look at the concepts of task sharing and competency sharing. The way in which responsibilities with more complex patients with multimorbidity, with frailty and so on, where you need team working and where there may be several people within the team that may do the same thing. They complement each other, and also there may be a degree of overlap so that if one of them isn't available, the other one can fill in for them, so you're not hanging around while you're waiting for the physiotherapist to arrive to get the patient out of bed or something like that. We also need to look at the role of families. We can't stay the same. Change is essential because everything is changing. We've got changing patterns of disease with multimorbidity, with aging populations, frailty, antimicrobial resistance. The whole nature of healthcare has changed. Think of what happened with the onset of HIV, for example. It fundamentally challenged our understandings of patients' rights, of confidentiality, of infection control, of all sorts of things. So we're seeing major changes in the pattern of disease. We have new technology, minimally invasive surgery. Many operations that once would have required the abdomen to be opened from top to bottom can be done through endoscopes. Intravenous anesthetics mean that people recover much faster than they once did. We have new diagnostic kits and microarrays, which mean that you can get results at the bedside instead of sending some blood or something else to a laboratory. We've got artificial intelligence for image processing, which in some cases will perform better than humans. And we've got telemedicine. And then a third thing that we have is the changing professional norms. Everywhere appeals to authority are being rejected, whether they be police officers or school teachers or doctors. Everybody is having to justify what they are doing. And you can't just say, we've always done it this way. We will always do it in the future, because that just doesn't work. And of course, we've got the growing autonomy of non-physician staff, recognizing that there are other health professionals who have their own professional standards, their own professional rules, their own disciplinary procedures, their own regulatory systems, and who can work autonomously and are not simply lower down in a hierarchy. The other reason why we need to change is we don't have enough health workers. We don't have enough doctors, and we can't substitute them for nurses because we don't have enough nurses either. We have shortages of almost everybody that you might want to be working in healthcare. We put cost containment in brackets because the WHO definition was all about doing things cheaper. It was about saying that people with high levels of skills should transfer the roles to other people working to them. And that's fine, but we need to remember that if other people take over roles being undertaken by highly skilled health professionals, well, maybe that makes them highly skilled health professionals too. And we need to recognize that that needs to be recognized and rewarded. You cannot just ask nurses, for example, to do all the things that doctors are doing, or many of them, and then expect them to have the same status, the same terms and conditions, and so on. And then we have the decentralization of organizational structures, again, disrupting some of the traditional hierarchies. The problems we have in trying to achieve change are that we don't have a great deal of evidence. There is research on task shifting, quite a bit of it in total, but is really concentrated in a few countries. And this reflects the weaknesses in health services research in many parts of Europe. Lots of evidence from the United States, but a different health system there. Quite a bit from the United Kingdom, from the Netherlands and Scandinavia, and much less, and Italy, and much less from other parts of Europe. We have the threats to power in established hierarchies, especially when there are financial interests involved. Now, the economist Adam Smith famously said, and he was talking at a time when it was a male-dominated world, that it is very difficult to get a man to understand something when his income depends on him not understanding it. So we have to recognize that we have often put in place financial incentives of paying people to do things in health systems that make it very difficult for them to give them up to somebody else who will then get the money for doing them. And we sometimes have obsolete regulation. We have rules in law which prevent basic tasks being done by other people. So it's not easy, and we're not pretending that it's easy. Well, as I've said, it's really important now because we just don't have enough health workers. And we need to make sure that we use the health workers we have as effectively as possible. We need to have the right people doing the job, even though they may not be cheaper, but sometimes they will be. But it's morally wrong to waste scarce resources unnecessarily. So if you're saying that a doctor has to do something, even though we know from evidence elsewhere and from research that somebody with a lower level of skills can do it, then that money is denying treatment to somebody who needs it. There is an opportunity cost there, and that is morally wrong. We cannot justify doing that at a time when, as we showed in a previous report from the expert panel, there is a very large amount of unmet need in Europe. Improved quality of care. Those who do the job best should do it. In some countries, you have specialized nurses as stoma therapists, as mastectomy counselors, and so on, with that specialized knowledge, which is far better than a general surgeon the knowledge a general surgeon would have, for example. And we need to promote resilience in the health system, because in emergencies, we need different groups to cover for each other. You cannot have a situation where someone is bleeding to death and somebody says, I can't do that. I can't put in an intravenous infusion. I can't do whatever, because otherwise the patient will die. And that too is morally irreprehensible. So, changing roles. Well, we can think of it in several ways. We've got enhancement, which increases the depth of a job, extending the role or skills of particular groups of workers, saying, here we have health workers who are not fulfilling their full potential. How can we give them the skills and the expertise and the confidence to do that? Substitution or delegation, exchanging one type of work from one profession to another profession, breaking down the traditional professional barriers. And then innovation, creating new jobs. When I was a junior doctor, I used to take bloods every morning from my patients. Junior doctors in the UK don't do that anymore. We have phlebotomists who are trained to do that. I did the ECGs. Yeah, junior doctors don't do that anymore either. There's no need for that. It's completely crazy. Vaccines. When I was a child, doctors gave vaccines in the UK. I mean, that's, completely crazy. So we've got a whole series of things that have been where other people have taken on roles that they would not have done, and you get new people, new groups of people who are doing that. But we've got equipment, technology, in all sorts of ways that are changing things. So what did we do? Well, we looked more broadly. We were looking at task shifting from health professionals to patients and carers, between health professionals, and then to machines. So let's start by going through them. Task shifting from health professionals to patients. And actually, though we think this is a good idea because the patient clearly knows their condition better than anybody else. They're living with it on a daily basis, whereas their health professional is only seeing them at brief intervals. But the evidence base is actually surprisingly weak when we looked at this in detail. And the problem here is that there are often methodological weaknesses in many of the studies that have been undertaken, and there are some areas that really haven't been looked at all. We did find evidence of improved quality of life of patients with stroke and COPD. Although we also found that self-management of exacerbations of COPD could be associated with higher mortality. So you do need to be careful. And this is a point that will come through all of this. It is not enough to say that something should happen. It's not enough to say it's common sense. We do need the evidence because this entire literature is full of things that seem like a good idea, but then when you do them, in fact, the results are not what you expect. And then patients should be able to do much more with technology. As I say, all of you, when was the last time, has anybody been to a travel agent in the last year? I mean, you do everything online. You organize all your own travel. So why have we not changed in healthcare? So you would expect that technology would be able to help, and particularly when it involves some of the more complex mathematics. So control of oral anticoagulation. When I worked as a junior doctor in cardiology, I had all these cards. People came in for their clotting times and things like that. I had to adjust the warfarin levels, and it was based on, frankly, guesswork. Well, now, of course, with algorithms and with computerization and so on, it's obviously going to be much better. And it doesn't need a doctor to do that because patients can get better results. But not with everything. So pulse oximetry, for example, we thought might be something that would work, but it apparently doesn't. The evidence is not in support of that. What about community workers? Well, here we were able to draw on a recent umbrella review that my team had done, which was looking mainly at low and middle income countries. And what that showed was that in those settings, and this was mainly doing fairly basic tasks, a lot of work in countries in Africa, Ethiopia in particular, but also some middle-income countries, that services provided by volunteers are often not inferior to those provided by other health workers, providing they're doing fairly limited roles. We're not pretending for a minute that you can bring a person as a volunteer off the street and ask them to do a coronary artery bypass graft. And they perform less well with more complex tasks such as diagnosing and counselling. But they can be helped. Their performance can be strengthened by regular supportive supervision, in-service training and appropriate logistic support. And if they have community ownership, it can work. So, as I say, mainly for under-resourced areas, but there are under-resourced areas in Europe where it is very difficult to retain health professionals, the medical deserts that we talk about in France, parts of Romania, Bulgaria, where there are serious shortages of any health professionals, so perhaps we could look at some of these. Task shifting from health workers to machines, well, there's lots of opportunities here. We've got apps of all sorts, digital imaging processing in radiology, sperm count hematology and so on, automated production in laboratories, wearable technologies. How many people are wearing a Fitbit? Anybody wearing a Fitbit? Or have you given them up because the evidence isn't really that good? I did have one, but I'm not using it anymore. And robot-assisted physiotherapy and rehabilitation, automated hospital coding, medication dispensing systems, artificial intelligence. Lots and lots of opportunities. But what do we find? Well, once again, the evidence base is surprisingly weak. The methodology in these studies is often really remarkably poor. The potential is there. Clearly, these things should be able to help. And there are some benefits in limited areas. But this is an area where we have a massive problem of conflict of interest. And as we show in the report, studies that are funded by the manufacturers of these things are not surprisingly, vastly more likely to give positive results than studies that are independent. I mean, this is true with tobacco-related research, nutrition-related research, everything else, so it's hardly surprising that it's also true here. And as we look at machines, there are major concerns about abuse of data, because if you're being given software for free, somebody is making money out of it somehow or other. And we find that people are now willing to enter the most detailed personal information, or not even enter it, but have it collected about them, about their menstrual cycle and about their sexual activities and all sorts of other things, which are of course being harvested by apps on your smartphone or on your wearable technology or whatever. And more we're seeing that the regulatory system that we have in place for that is really not fit for purpose. Now we come to the main bit that many people are most interested in, task shifting between different types of health workers. And we find a lot of studies that show that nurses achieve similar outcomes to doctors when managing routine conditions. So people with a single condition, diabetes, asthma, something like that, then nurses in the routine management perform as well as doctors in randomized controlled trials and many other studies. And actually, nurses often provide better patient satisfaction. And I speak as a doctor, although one married to a nurse, and that's probably because the nurses listen more. But the downside of that is that nurses do tend to recall more patients and request more investigations. Now, I'm generalizing here, but this is something that comes out again and again from the studies. And the results are less clear for more complex conditions. So experience training does count. If you've got somebody with complex multimorbidity, you will get better results from a doctor than from a nurse. But there's a lot of things where that's not the case, and as we say, often nurses actually get better results. I picked out a few examples. There are many examples in the report. Nurses are as good as doctors in routine preoperative assessment. Pharmacists achieve better results than doctors in medicines review and add benefit to multidisciplinary teams. Prescribing by nurses and pharmacists in routine care often achieves greater adherence. But the evidence on enhanced roles of nursing is somewhat mixed. Sometimes it works, sometimes it doesn't, and you need to look on a case-by-case basis. So let's try and summarize what we find with all of this. There is little evidence for the rigid demarcation that there is between different health professionals, such as doctors and nurses in many countries. Groups other than physicians, and especially nurses and pharmacists, can undertake substantially expanded roles compared to what has traditionally been the case. But they must be adequately trained and supported and function in integrated teams with information sharing. And maybe the big message in all of this is the idea of the single professional, the single doctor. Thinking of my parents' time as general practitioners, two doctors working together in a practice with a receptionist and with a nurse or a midwife coming in from time to time. I mean, that's gone. That is no longer justified at all, but it's still the case in many countries. So it is team working to deal with complex multimorbidity and the challenges of the future. We need to understand, there's a need to understand much better the optimal combination or package of changes that need to be made. Basically, you can't just change one set of tasks without changing other things. You may need to change the regulatory system, you may need to change the pay system, the incentives, and so on and so forth. And while we don't need to evaluate every change, because there are some things where it's perfectly obvious that somebody can do something as well. I mean, vaccines is a good example. If you're doing major changes that have major implications for the organization of the hospital or the clinic or whatever, then it is important to evaluate it, because we do find that there are unintended consequences. Hierarchies are a function of power relationships, they're a function of social relations and the way in which the system works, so we need to think about that. But just because these things are difficult is not an argument for doing nothing. So, we then looked at enablers and barriers, and we have to act. Staff shortages, increasing complexity of care. But of course, there are some problems. There may be legal barriers about who can do what in some countries. These are obsolete, they're often long, they were brought into law decades ago and bear no relationship to modern practice. Professional associations, I declare an interest. I am a member of the British Medical Association. I'm a former member of its Committee on Science. And I recognize that professional associations play a very positive role. But they don't always play as positive a role as they might do. Now, this does vary. The Royal College of Physicians in London, of which I'm a fellow, has been in the forefront of working to promote physician's assistants. Now, there's a lot of tensions about that, so some are doing much better than others. Financial incentives are often a barrier because it does mean that some people will be losing money. Changing professional attitudes is positive, particularly with European mobility and people seeing how things are done elsewhere. Pilot projects are a good idea, but not everywhere has the capacity to implement changes. Often what we're asking is not a major change in what really happens. We often talk about the law on the books and the law on the streets, because in many cases the changes that we're asking are already happening informally. Nurses are doing things that they're not meant to be doing simply because it's the only way of functioning. And there are obvious challenges about legal indemnity for other professional groups. We picked out this example as the Calderdale framework as one that we found in the literature that has been evaluated and does seem to work. Raising awareness of the need for change, analysing what's actually happening, looking at the different tasks that people are doing, and in particular looking at the risks, identifying the competencies that are needed, and then supporting people with training, and then sustaining it and going all the way around. So people have been doing this. It works. It isn't maybe used everywhere, but we just found this. We don't have any, I mean, there may be other frameworks, but this is one that did seem to work. So what do we recommend? In all cases of task shifting, we need to be clear what we're trying to do. We need to know what our objective is. We need to know why task shifting is the answer to the question that we want to answer. And we need to know the evidence on which our decision is based. We need more research. Now, I'm a researcher, so I would say that, but we do need a lot more research on task shifting. And in particular, we need research in countries where there is so far very little research. And that is true of many of the countries within Europe. Because we need to know what works, and we need to know what works in what circumstances. We recommend that those responsible for training health workers actually actively promote the idea that people will do different things. We want to convey positive attitudes to interprofessional and team working, and we want to look at the ways in which interprofessional learning experiences can help. And we need to provide the skills that are necessary for task shifting where we know that this is likely to be effective. We want those who are responsible for implementing task shifting to engage in dialogue to understand the expectations and fears of those who will be affected by it, including patients and their carers. And this can be challenging for people, things that we've done for many, many years, and then we're told, well, you don't need to do that anymore. And that's threatening to people's jobs, their income perhaps, and they may be very nervous and very worried. So we can't just tell people what to do. It's just not a matter of issuing an instruction that will happen. It needs to be done in a shared way. Those who are responsible for health services really need to understand the organizational culture of the services that they're responsible for, and this should promote flexible approaches. Now, this is not specific to task shifting. Some of you will be familiar with the magnet hospital concept developed in the United States and now being trialled in Europe. And that has flat hierarchies with the ability of different professional groups to challenge each other. And the simple reality is that in those hospitals where you have a non-hierarchical approach, where you have empowerment of nurses, fewer patients die, which is important. We recommend that legislative and regulatory authorities review the rules that exist and assess the extent to which they put barriers in the way of more flexible ways of working. And they should recognize that we should be promoting more flexible ways, not seeking to obstruct it. When we look at task shifting to patients and their carers, we should recognize that the goals, the expectations, and the capacities of those undertaking new roles will be different, and they need to be empowered to engage fully with health workers to design their care package. It's not just enough to say, you're in charge now, we're leaving you on your own. People need to be supported in these roles. They need to be trained, they need to be helped, they need to be assisted. So it's not just a matter of dumping care on them, and that unfortunately is what is happening in some countries, including the one that I live in, where cutbacks in health services are leading to a transfer of responsibility to patients who are left unsupported. We recommend that decisions to engage in task shifting should be planned carefully, because it's not just that there are implications for people, the individuals concerned, but also implications for the wider health sector. And with that, I hope that's given you an overview of what is a very detailed report with hundreds of references and lots to read, and setting out the challenges and the opportunities. And I will stop and we can take questions. Thank you.
Now, I'm sure that on behalf of all of us, I can thank Professor McKee for an excellent systemic summarizing of an extremely broad issue, which is task shifting, and especially for highlighting that task shifting is not necessarily just a tool for patching situations of not having enough persons or not being enough efficient in health systems. It is an opportunity, as Martin has said, and it can also be viewed as a threat, and vice versa. That's how things happen in life. I would like to bring your attention that when we meet after the coffee break, which will now last till about 12 o'clock because we have ample time, and I would like you to discuss some of the issues presented in the couloirs before we meet here again, then what follows is not a discussion. What follows is basically we all would like to hear your views representing the contexts of your communities where you function, of the issue of task shifting, of the potentials, and obviously also of the risks. It is not just about doing the things, it is about knowing how to do these things, and I think that this will be an important issue that will be highlighted by the views coming from your communities. So we can now have a coffee break and we will convene here again at 12 o'clock sharp, please.
Yeah, maybe we can move it forward.
Well, shorten the coffee break to 15 minutes. It's against my philosophy because, again, you have not been to travel agents for a long time. I used to go to conferences to get information. And that was 20 minutes of getting information and 5 minutes to get a coffee. Today I can get the information online, and when I set up conferences, I set them up the other way around. 5 minutes for presenting a summary and 20 minutes for socializing, which cannot be done online. Nevertheless, my colleagues, 15 minutes break, we meet here in 15 minutes. Okay, can I please ask everyone who intends to participate to come back into the room? Okay, it was great to watch you during the break and to see you now. You should see how many of you have a smile on your face. It was not so when we met. Uh, and it doesn't look artificial. So I think that the couloir and the food and the possibility of personal interaction had its effect. I would now like to hand over to Luigi Siziani, who will lead the moderate the discussion. So the floor is open.
Yeah. So just to a couple of reminders. So this is the part where we open up to discussion. So if you could state your name, your organization, and if possible, if you could also flag which part of the opinion you would like to comment on, that would then be quite helpful for us to know where to look at. So this is really your opportunity to give us your thoughts about the opinion. Over to you.
Good morning. I'm Stefan Gijsels of Digestive Cancers Europe. So we represent all cancer patients with cancers of the digestive tract in Europe and outside the European Union as well. First comment is basically with regard to the type of interventions and stakeholders that you mentioned. For doctors, typically, and other healthcare providers, managing a disease is a succession of individual intervention points. So there's a moment of diagnostic, there's a moment of treatment, there's a moment of consultation, there's a moment of this, that, and the other. From a patient perspective, there's one continuous flow. And so it doesn't matter when how the diagnostic is made or by whom the diagnostic is made. The question is, when is the diagnostic made after the initial complaints to a doctor? The question is not only what type of intervention or who does the surgery, for instance, or administers whatever is being done. It's when is that being done after the diagnosis has been made. And there's a lot of inefficiencies in the system. So my recommendation would be, or my comment would be, there's a lot of work and intelligence in patient organizations. We see the inefficiencies in the system because we follow the entire patient journey. I am personally convinced that we can reduce 30% of the costs and increase 30% of overall survival by managing the system in a better way than is currently done. Every disease will have its own specificity on how that should be done. You cannot make a one-size-fits-all concept. Mental health is something else than cancer, is something else than diabetes or multiple sclerosis. So I think if you want to come with recommendations, you have to do it in a very disease-specific way. The reason why I mention this is because there's a lot of value to be gained by looking at the patient journey and see how it can be made more compact, what can be done. We know, even in the richest countries, which hospitals guarantee a certain death and which hospitals guarantee survival. We know what the importance is of non-medical consultation to patients in their recovery. What does it mean to be physically active? What does it mean not to be socially isolated? What does it mean to continue to be professionally active? Nobody in the health system cares about that. It's all about intervention, intervention, intervention. And I think it would be much more wise if patient organizations could be part of that process in a more systematic way. The problem is for the ones that demonstrate it and have the results and demonstrate the results, nobody is willing to reimburse the effort. And the second is, if you want to have research money for this type of effort, there's no money available because it's not technology driven. So again, I repeat, a lot of advantages can be made by respecting patient organizations and giving them a more significant role in managing the patient journey. Thank you.
Okay, thank you. So I think these comments relate to patient pathway and the organization and patients' organizations. Martin, do you want to?
Yeah, sure. No, I mean, you raised an interesting set of points. So you made quite a lot of statements about what we know, and that's great. If you know that, do send us the references in the peer-reviewed literature. We'll be very happy to look at that, about the 30% reduction in costs and 30% reduction in mortality. So if that evidence exists and we haven't found it, we'd be delighted to hear about it, of course, providing it's in peer-reviewed journals. You make a point about pathways being disease-specific, and yeah, of course that's true. I mean, we work in another role. I'm working on the International Cancer Benchmarking Project, and we're looking at patient pathways, which are incredibly complicated even for individual cancers. But of course, the problem is that patients don't have one disease nowadays, or most of them don't. So the challenge is with that of multimorbidity. So in a way, the danger of going into a disease-specific model would be to go backwards away from the complexity of people. Well, you disagree, but do tell me why. Because if patients have cancer and diabetes and heart failure and something else, surely we need to take account of the holistic needs of the patient and not just one organ. But do tell me if you seem to disagree.
At the moment, there is almost no follow-up on patients. The patient coaching in the entire patient journey in most countries is not done. And that's also because of not only because the system is organized that way, but also because the patients lack the discipline to do it in the proper way. I think there is a significant difference between patients who are part of a patient organization, get the necessary coaching, get the necessary guidance, and follow up to do whatever is needed.
So what you're saying is the patient organizations are doing this?
Not all. And I think that's one of the claims. I think in 10 years from now, most patient organizations will fulfill that role.
Okay, I'm just trying to work out what this means for our report. Sorry, I'm missing something here.
I'm saying that there's a shifting role from the current healthcare providers towards patient organization in the future.
Yeah, okay.
Yes.
Well, if you have literature on that, published literature, we're very happy to incorporate it. We didn't find any, but that doesn't mean it doesn't exist.
That's the reality, and I think not everything that we do is published.
No, I know. But what we've said is we can only go on the evidence.
I mean, we are ignored to a very large extent.
Well, I'm not sure that's the case. I mean, patients' organisations have a very strong voice in Europe, so the fact that you're here and we go to many meetings, but that's another issue. And I'm not sure also about the idea that patients' organisations are not able to get research funds, because they do, and they fund research. Cancer Research UK, I'm not sure if you'd call it a patient
organisation.
Well, sorry. Okay, but there's no reason why patient organisations do work in collaboration with researchers often, and particularly in countries where there is an emphasis on pathways to impact of research. Yes. There's a clear recognition of public and patient involvement. So I think if you look at the public and patient involvement literature, you'll see that there's a very strong impetus from some research funders to involve patient organisations as partners in the research.
But very often we are token participants in research projects. I really wish that we could be able to get funding to demonstrate the actual value that we deliver in terms of efficiencies and effectiveness in patient outcomes by managing the patient pathway in a different way than is currently the case.
Okay, but
give a control group and one in the patient group, and I'll show you the difference.
Sure. Oh, no, that's fine. But I'm just puzzling because I find it very difficult to see any funding bodies that actually exclude patient organisations as grantees. As far as I'm aware, certainly the ones I'm familiar with, they would actually encourage that. So it is up to the patient organisations to develop the research proposals with academics and then to apply for that. But unless if there is a, I'm not sure it's directly relevant to this report, but if there is a legal restriction which says patient organisations are excluded from funding, then that should be dealt with, but I'm not aware of that being the case.
Okay, so maybe we can move to, so I think there was one question down there, yeah.
Good morning or good afternoon already almost. My name is Jan de Beli. I'm a community pharmacist and representing the European Association, the PGU Pharmaceutical Group of the European Union, the European Association of Community Pharmacists. First, I would like to comment on the recommendations, which I think are very well balanced and that they cover some very also important challenges and conditions for it, such as in every task shifting, ensuring appropriate training and support for the new healthcare professionals, as well as what was I saying? Forgot my second point,
but you like the recommendations anyway.
yeah, no, exactly.
The
It was,
important point.
No, but also exactly that was it. That there's no one-size-fits-all approach, because that sometimes polarizes a bit the debate on task shifting or diversifying roles in professionals. We have to look at the national or sometimes even local level to see what is really the need of the health system, the patients, but also, I mean, exactly as workforce shortages concern. Point on the terminology. So I see indeed the mandate is on task shifting, and that you also included that this also covers task sharing and task distribution. I would indeed maybe as a recommendation to emphasize this a bit more, that it also covers the task sharing and task distribution, because for instance in the examples I see more focus on task shifting. For instance, take the point on pharmacists, there is a focus really on medication reviews, medication management. For instance, there's no focus on, for instance, prevention, screening services, such as smoking cessation, in which there's also quite some evidence. There's no particular focus, for instance, on the role of pharmacists in supporting minor ailments, such as, for instance, is the case in Scotland, where as a reaction on a shortage of GPs, pharmacists had an enhanced role there. So just in terms of the terminology, so that this report, because I think the terminology in this debate is quite important, because it can often give some difficult discussions when you see task shifting. I would personally see it as a bit more a negative word, whether task sharing or task distribution is better reflecting what is going on in practice. It's saying that instead of moving away a role from and especially talking about primary care, from a physician to another provider, it's opening up, ensuring that those other providers have the sufficient qualifications and competencies to perform this role, but that it's about multidisciplinary collaboration. With task shifting, for me, but that might be a personal thing, it sounds a bit more as we move it from one to the other side.
Yeah,
that
but
was just
I mean, we do reference in it research showing that having pharmacists on ward rounds improves the medication management. So I think we do pick that up a bit. The difficulty, of course, is that we can't cover everything. I mean, it already is a very heavily referenced report, so we can't go through the things that doctors do, and we don't show that doctors can do cardiac surgery. We know that. We don't show that nurses can do advanced nursing. We know that. So it is about the distribution. It's a comparison that we have tried to pick up. So the studies that we looked at were the ones where there is some degree of comparison, and those are all interesting points, but I think they probably go a bit beyond what we can what we can put into a report, because as you say, what's important is the recommendations we end up with, and they are evidence-based. So I think what you're asking for is just more detail, and it wouldn't change fundamentally what we're saying, I think.
no, exactly, but it's just also on because in this debate, let's say the terminology is important, I think, for health.
Which we do say. I mean, we said explicitly, as you saw, we do go beyond the traditional task shifting definition, so I think we agree on that.
Very good. No, but that's, I would say, just that was my only remark. Another, I would say, congratulations.
Thank you very much.
Good report.
Yeah, very short comment. We have also addressed it on the level of education, because that means the change of culture. It's not anymore, this is my thing and I will not hand it over to anyone. It's about collaboration on the level of team collaboration, and that has to start with continuing professional or vocational education, which is also addressed.
I think that actually the first question was first down here. Hans, sorry, or are you happy for the other questions to go first? Yeah, please.
Okay, very quickly then. Good afternoon, thank you. My name is Dorota Sienkiewicz and I work for EuroHealthNet. I was here yesterday already, but I will say who we are. We are a European not-for-profit partnership of organizations and institutions, national public health institutes, for example, working for better health and reducing health inequalities in Europe. I have a couple of points. First of all, I also wanted to thank you for quite a comprehensive draft opinion, and the issue is certainly a kind of urgent one, important one. The actions recommended are reasonable, given the very limited evidence that was already mentioned, which is much less than desirable, and certainly from underserved sectors and other parts of Europe. So we would certainly support it in terms of calling for further evidence, including health equity impact assessments, because this is what we've been working on, and this is an issue that we see quite a big potential of this being maybe taken a little bit more into account here, and also learnings from other sectors and from comparable settings and models. And we would be interested to see how this could be done via EU research and health programs, but also the other EU-funded programs and tools. And then taking it to the issue of principles of equity, health equity and equality. Professor Marquis, you mentioned that the evidence, the evaluation is needed. It's difficult. Certainly shouldn't be an excuse for inaction, and I couldn't but agree with that, of course, because for us the strong focus should be put on ensuring that the task shifting in healthcare settings strengthens and not undermines the principles of equity and quality. It shouldn't be viewed in isolation, but in the wider context, outside of the narrowly defined health systems. So from a whole systems perspective towards well-being and improving people's and healthy populations' quality of lives. Another point that I have is on the community workers. They are mentioned, but they are mentioned in terms of requiring better integration into the health and care systems, while it is our kind of observation that in real world the opposite could be also true, that health professionals could and need perhaps to be better integrated within wider public health workforces and systems, and that includes public, private and voluntary sectors. On the issue of changing roles of health care professionals, the changing roles of patients and healthy populations should be also considered, and there was also a point recommendation made on supporting and assisting and building capacities of patients and their families and carers on which the tasks would be then shifted. And with regards to that, I wanted to mention an issue that wasn't really mentioned in the opinion, which is investing in health literacy of patients and healthy populations, and especially the digital health literacy now with the shift onto technology and uptake of digital health solutions. That's it.
So, yeah, that was an awful lot of points, but can you just focus down to what the key message was there? Because I sort of got lost a little bit, because I think we all agree that health services should be about promoting health and well-being, and we don't feel we need to say that again and again because it's so obvious. And that seemed to underpin quite a few of the points that you were making.
Yes.
But was there something specific that we should be doing?
On calling for evidence, I'd say including the health equity impact assessments into.
How would you do that? I mean, I'm really interested because, it's difficult enough to get good evidence on the things that we're asking, the direct focus. I mean, we obviously all agree that health equity is important, and we've published other reports on that. Totally agree. I mean, that goes without saying, but maybe take me through just an example, a specific example of one of the research studies that we did, that we reviewed, where one could have added a health equity lens to it. That would be really helpful.
Right now.
Yeah, sure. No, but I mean, you raised the issue, so I'm fascinated to know how you would actually do that, because clearly, all the way through the report, when we're talking about the sustainability of health services, we're saying that there are major problems in human resource, in health professionals in parts of Europe. We talked about medical deserts in France. We talked about depopulation of rural areas in Romania, Bulgaria, and that's all about equity. So we're absolutely clear on that. I mean, totally. It is inequitable for people to be living in Europe in areas where there are no health professionals. And that's actually the rationale for our report in a way. But I'm just not sure how you would go beyond that to incorporate a specific equity element, other than saying that if community health workers or other people can do things and maybe they're in an area, I mean, that surely is bound to at least help equity, at least it won't undermine it. And I don't think we're recommending anything that will undermine equity unless we...
That wasn't my critical point. I was just saying that perhaps it could be a kind of emphasized a little bit more. I mean, in our view.
Well, no, we're happy to do it if you tell us how. But other than saying, yeah, of course we're committed to health equity. I mean that.
So Martin,
turn it round the other way and say, well, actually, we want to undermine health equity. Well, obviously we don't. So I'm not sure we need to. Do we need to say it?
But Martin, let me maybe moderate this. So I mean, one way I interpreted your comment was that when the evidence looks at the effects of task shifting, perhaps they might pay more systematic attention to health equity, which probably applies to many other topics, not only task shifting. So I think if that's the point, that's something that we are aware of, and maybe we'll consider how to tackle that.
I think you'll find it does underpin a lot of what we're saying.
So, okay, let's move on to the discussion. So I think Hans, you had a comment.
Hello, good morning. Hans Winberg from the leading healthcare foundation in Stockholm, founded by the Stockholm School of Economics, which makes me an economist.
Sorry, from where?
Stockholm School of Economics,
okay,
leading healthcare foundation.
Yeah.
We work with governance, leadership, controlling in the whole health sector. My comment is on the definition of task shifting, or where you are going in this report. Basically, there are three different forms of societal coordination. There are markets, there are hierarchies, and there are networks. That's what the literature within economics, sociology, and so it's a different. You wouldn't find them if you go for the medical publication databases, because it's other disciplines, so you wouldn't find them. This certainly refers to the hierarchical definitions of task, and I think that it's a very good point you make when you say that this is depending on the laws, the regulations, the systems, and also medicine has become very hierarchical over the times. It's a hierarchical built profession. With hierarchies, both vertical and horizontal, in that it's defining who can do what. And I agree with the local pharmacist here that this is about moving tasks to other ones and see if you can do it better and if you can do it on the lowest possible level. But I think that's necessary. We need to look into that, because we need to see how we can task shift and not being stuck in a conservative manner that only this person can do that. For instance, patients couldn't do much before, but they can do lots of things now. So that's changed. The reality has changed. But I think it's not sufficient, because I think we should go into the network part of it too. And there's a concept of collective intelligence, that our intelligence can actually exceed our own personal individual intelligence if we distribute it right. But that's not about task shifting. That's about building relations in order to know what the other is doing, be trustful in the relations, and then also be able to act smarter and divide according to context, which is nothing you can do in a hierarchical way, because if you believe that you can sort of pin that out on the beginning, you need to live in a planned economy, and we've seen how those went. That wasn't so good. You need to have some kind of agility in the microsystem, and those relations are in the microsystem, not on the macro level, which we are talking about when we're talking EU policies. Not in the meso level around managers and strategists around the healthcare organizations, but in the microsystems where patients and health professionals are. So I think that that's lacking. I don't see anything about the network building, the not task shifting, but building on competences as a team. I see that you talk about it, but it's not in the recommendations, and I don't find it in the literature review, because I don't find the literature on collective intelligence, and there's a rich literature on that we know. And I guess that it's because this is around social behavior and social relationships. So I think you have to look outside of medicine. And that brings me to my last point, which also reflects very much what Stefan said. We have to talk about evidence. And more profoundly, we have to talk about knowledge. How can we get knowledge? What is what's the ontological status of knowledge? Is it movable? Is it social? Is it defined in the context, or is it there? I'm not talking about fake facts or anything like that, which I know that very often you talk about that. I'm talking about informed theoretical perspectives on different things that aren't as solid as a pure natural science fact.
Okay, so thanks for this comment. Before I pass it to Martin, so what I hear is, in some way, elements that we have covered to some extent in the opinion, which relate, maybe we labeled in a different way, so that related to team working, culture, and the professions. Then, you know, as anything, you could go a little bit deeper in any of these aspects. Perhaps I do not accept that we didn't look at the evidence, because I think that the evidence was extremely long, but then I'll pass it to Martin.
Yeah, I mean, I'm a bit surprised, because everything, I mean, the entire the thread running through this report is challenging hierarchies and moving to networks. Even if we don't use the language, we talk about substitution, we talk about people being able to cover for each other, we talk about the need for, with increasing complexity of patients and so on. So I just wondered if we didn't draw on, I mean, we couldn't draw on all of the literature from organizational theory to management to governance. There's a huge wealth out there which
that's actually what I'm saying. I know that you can't do that. And I
mean, I could do it because I've written on it elsewhere, but you know, we can't.
But I mean, there are also other scientists that work in those fields that actually could do it much easily.
No, we could do it ourselves. I mean, you know, if you look,
but sometimes you shouldn't do. That's about task shifting. Sometimes you should.
No, I mean,
if you believe in task shifting, you should know you should actually use the right competences for the right tasks. And I can say I have 30 years of experience of this now with the whole medical community in Sweden and so on. It's changing. It's actually changing.
Yeah.
But if you see that there are, I mean, if you try to do a randomized controlled study on task shifting, you will probably fail because it's the wrong method. It's absolutely the wrong method.
Well, actually,
so
not,
what you're going to find is that water is important to ships.
No, actually, that's not the case, because if you go to the European Society of Cardiology in September, we will be reporting the results of a cluster randomized control trial of task shifting. Now, I can't say what the results are now, but we have done a large, well, I mean, you can easily do a randomized control trial of task shifting. Not easily, it's a lot of hard work, but I can absolutely assure you we can do it.
But I say that the effects you have of that, there are faster, more appropriate ways of
there are other
achieving
ways.
Teamwork that I know that probably many people here know about. So
yeah.
So, but that's also about about respecting each other. And
yeah,
stuff
no.
Like that. But if you don't do that, I'm going to sit down.
Okay.
Yeah, no, I'm sure, but I think that runs all the way through our report.
I'm a bit irritated. Okay, thank you.
And there just is a literature. There's a limitation to how many different literatures you can incorporate in a report that is meant to be reasonably practical. I don't think we disagree with anything that you're saying.
That's why I said that it's perfect within that sense, and it's hierarchical. If you should do this is about the hierarchical and how you define each professional group's tasks.
Which
and you also mentioned doctors, you mentioned nurses and pharmacists. I haven't seen a single UX designer, for instance, which is why the private industry is surpassing all the things coming in from within healthcare when it comes to digitalization. That is actually, it's the classical Schumpeterian creative destruction that is happening now. And we have seen it in Sweden, and The system tried to fight it, but they lost. So now 2 million visits are done through new actors' digital systems. And the professions are starting to move there because things happen faster. So it's just, that's not about, that's not, has nothing to do with medical evidence, because it's just different forms of distributing the evidence we actually know.
But I think it's important to stress that it's not that we're unaware of this literature. I mean, there's an entire literature in the sociology of professions, Friedson and others, which we could easily have put in there, but we didn't, because we can't get into being a textbook on the sociology of professions or on power relationships and Luke's theories of power and all. So there's plenty of theoretical perspectives you could have put in, but the danger is that then it becomes, first of all, impenetrable for many people, and it would be 1,000 pages long if we were to put everything in, because you rightly pick up one area that we could have developed, but there are, I can think of at least 5 or 6 other areas of scholarship that we could easily have put into this, all of which would have expanded it greatly. So I don't think we're disagreeing, and I think within the panel we could certainly address those issues, because we are familiar with them. I mean, we are familiar with the literature on markets and hierarchies and make and buy and all the rest of it, and particularly the work that the bank has done.
Make and buy is not so interesting.
Okay, I think I would like to move on. So I think Alice would like to make like a final comment on this point, and then we move on to the next comment.
In relation to this, I would like to cross-reference you to a report we did on digital transformation of health services, because there is a chapter exactly on the decentralization and shifting to networking. That is also the reason why we didn't include it so dramatically into this report, but based on your comment, we will probably cross-link it to the later report.
Okay, so let's move on to the next comment, please.
Thank you. I'm Jacques Dihaller. I'm Vice President of the Standing Committee of European Doctors. I'm very thankful to be here to discuss that. I want to thank you for inviting us. It's definitely a huge topic. Professor McKee, the CPME position on task shifting might please you, at least sure mostly. It states that the shift of some tasks may enable use of manpower and resources, better use, free valuable time for physicians, and therefore contribute to better care for patients. That's a nice part of it. In order to guarantee the safety of patients, this should always take place under the condition that the responsibility for diagnosis and therapeutic decisions cannot be divided and remains with the doctor. That might please you a little bit less. But it means clearly, and you were asking for the feeling of our constituencies in this hearing, we are not allergic to task shifting at all, period. I mean, and I want to stress that. It's not an ideological opposition, it's a practical patient safety, quality of medicine idea, but it's not an allergy. Now, I've heard the representative of patients suggesting to cut the budget, the health budget, by 30%, and I'm kind of surprised. I would prefer to have more money for healthcare, and this will become necessary. I mean, we just can't do with the money we have for the next decades. And as doctors, we won't accept to be satisfied with cheap medicine just because it seems cheaper. And this, moreover, with no good sufficient evidence. I want to note that there is also a shortage of nurses. We discussed that already, so we're not going to be able to replace doctors by nurses. We don't have enough of them either. And by the way, those choosing one profession or another don't necessarily want the same thing, don't have the same vision for their professional life. I don't think we can just shift people from one function, one role to the other. We need a better allocation of resources, but be careful of people. You center it on tasks, which is, of course, one methodology, but I would suggest also centering on people. One more thing I want to mention is the fact that there is the need for an overview, a coaching overview of a patient's situation. And this is the task of one who has a broad enough education to do that. I don't think that my colleagues studying 10 to 15 years and training go mainly to the pool or drinks or have drinks at the cafeteria. They learn things during these 15 years, and this should be taken into account. It's necessary to have a broad overview of the medical field, of the health field, to coach patients in difficult situations on the long time. And particularly GPs are, of course, in my view, the best people for that. 2 short remarks and then I'm through. One is about the task shifting to patients. I was surprised not to see more mention of the self-care initiative of the EU, of the Commission. It was discussed and studied a lot on self-care and patient empowerment in the self-care project, however it was named, which was finished Peace, and that was finished 1.5 or 2 years ago. So it's quite actual, and maybe you might want to refer to that. The last remark is just a joke. But Professor McKee, if your computer had crashed a week ago with this whole report on it, do you hand it over, your computer, to your 11-year-old nephew because it's less expensive and he's right there by chance? Or do you refer to your computer to a specialist? I think we should really keep in mind that task shifting is important and justified, but not as a solution to money problems and not without regarding the people's and the patient's interests. Thank you very much.
Yeah, I think we're actually agreeing with you. I mean, we are very clear. You'll
No
see
surprise.
I put cost containment in brackets because that's the argument that's often used for it, and we're challenging that. You know, we're explicitly saying this is not a way of, you know, this should not be done primarily for cost containment. You know, in terms of specialist knowledge, I mean, absolutely. You know, I used to do endoscopies, upper GI endoscopies. You would not want me doing one now. It's a long time since I've done that. I mean, I've done several hundred of them, but
I don't want to need
things,
one.
Yeah. So you know, there is a case for somebody who's done them a bit more recently than me and has that expertise. So I actually. So is there something that I felt as I was listening to you, we were largely agreeing, except that where we do, I think, disagree is it is the issue of the autonomy of some of the other professional groups, because you were expressing it, I think, more as a hierarchy rather than a network, and I think we're moving away from the hierarchy.
I'm not a fan of hierarchy. I do think that teamwork is just essential in healthcare, no question with that. It needs very much communication, and if nurses or community pharmacists do things they don't do now in the future, it needs a huge communication effort with the GP in charge of the patient, in my view.
Yeah, and also I think the other point that you made is that, of course, doctors, anybody may have the technical skills, and that's great, but unfortunately, as we all know, not everybody has the communication skills. And given the growing evidence of, you know, we know, for example, from experimental studies, that if you give patients a series of myths and facts about vaccines and tell them this is a myth, this is a fact, they will remember them 2 or 3 minutes later, but 30 minutes later they will have forgotten them. So people's attention span is remarkably low. There's a huge literature on cognitive biases and optimism bias and so on. And in fact, there's a whole area of communication science which I think needs to be taken account of, and which is being done in some countries in general practice training, for example. I think the Royal College of General Practitioners in the UK does it well. I'm sure there are many others. Belgium, I think, do it well. But I think it varies, because not everybody, you know, not every country does have such a strong emphasis on communication skills in its medical undergraduate and postgraduate training. And I think expertise in communication skills is important too. So sometimes it may be better. And sometimes we may be looking at completely new ways of doing it. So for example, if you look at the work on tranexamic acid, for example, the way in which the group of the people working on that in major trauma have been using cartoons. They've been drawing on the manga cartoons from Japan as an example, and looking at cartoons, GIFs, short videos and things. So all of that is important, but we shouldn't just assume that because you happen to know the amino acid sequence of insulin that you can advise on the lifestyle adaptations that somebody with diabetes has. But I think we're largely agreeing.
That's fine. I'm happy with we agree. We just find it important not, as I said, to go into cheap medicine, and that's really our point.
And which we're not calling for either. Absolutely, we're not. We're saying, in fact, we are arguing explicitly against using this as a means of driving down costs, as I think was clear.
Thank you.
Thank you. Now there is a comment from the second line. Yep.
Yes. Hello. Yes. Thank you very much. My name is Rudolf Reibel from the German Medical Association, and well, the comment has been made before by Jan that the report is really not does not recommend a one-size-fits-all approach, which we appreciated a lot when we read it. One thing I would like to point out, which I found very positive, is that task shifting can also help relieving doctors and other health professionals from administrative tasks, which are getting more and more burdensome. And there is actually the risks that within the with the emergence and the implementation of e-health, this will still increase. So this is a very important aspect. So it's good that it's in the report. One thing we were missing a bit was a clearer distinction between substitution and delegation. Actually, it's written substitution/delegation, and as I see it, these would be entirely different things. The question would be where the responsibility lies. Does it lie with the doctor, or does it lie with a nurse, midwife, or producer of artificial intelligence software? If something, not only responsibility in terms of who gives the orders or who says what to do, but also if something goes wrong, who can be held liable. And maybe that's the lawyer in me talking, because I'm not a health professional by background. So the question of indemnity insurance and the question whether criminal and civil liability is enough, or whether you need a professional supervision. Would it be by professional bodies or by the state? All these aspects are relating to liability and should be or could be emphasized a bit more when you because this will play an important role when you draw the distinction between substitution and delegation clearly. Thank you.
Well, I mean, we do talk about legal indemnity. One of the difficulties is, of course, it's so diverse within Europe, and the whole issue of the regulation of professions differs. And we know this because some years ago we did a study in which we took a series of vignettes of behavior by physicians, some of which were clinical and some of which were professional and even social, like, sexual harassment and things like that. And we gave them to medical regulators across Europe, and we asked who would deal with this, whose responsibility would it be, how would you deal with it? And it was completely variable, completely different in different countries. And even the threshold for intervention, I have to say, you're much more likely to have a disciplinary action taken against you by the General Medical Council in the UK than in any other country. And that is why the UK contributes so much to the alert system within Europe. So there's huge diversity which we're very familiar with. And that makes it rather difficult to go into particular detail. Now, we could of course argue, but it's not the subject of the report, that we could go for a no-fault compensation scheme like in New Zealand. That might resolve the problems, but that's a completely different issue, but I think one that has a lot of attractions in it, although not if you're a lawyer. We pick it up a bit. Maybe we could do more, but again, the difficulty is we're writing for the whole of Europe, and while we're very familiar within the panel of the diversity within Europe, there's a danger of focusing too much on one particular country.
Okay, thank you. So I think there is a question there. Yeah.
Good morning. Good morning, everybody. My name is Simone Moors. I represent the European Hospital and Healthcare Employers Association, so it's a completely different angle from which it was mentioned before. We talked about healthcare professional organization, etc. And I have two comments, remarks, just to further explore this role, because in the entire report there was nothing mentioned about national social partners and how social partners can be also involved in this regard, because social partners are the ones that are setting the collective agreements and bargaining in some countries, thank you, on task shifting, or on basically on how to set how are doctors or nurses remunerated, etc. So I was just wondering if you at all came across any literature or research on this issue. And also you mentioned I think it's less than a page in total on healthcare professionals, which I think the colleagues from CPME can agree on. And you mentioned once the word of trade union, but did you come across on anything on employers in this regard? So, and again, thank you for the report. It was very informative. Thank you.
No, we didn't.
Thank you.
Okay, I think there was a question just next to
Good morning as well. My name is Joanna Enake. I work for Baxter. It's a medical device and pharmaceutical company. For the sake of transparency, we provide a range of treatments for chronic diseases that are available both in the hospital and in the home. So thank you very much for the draft opinion. It's very comprehensive. Maybe just a couple of additions. First of all, I would like to echo many of the comments that have been made here and additions that have been made here around patient empowerment to self-manage some chronic conditions. I think this is very important, and we should definitely invest more in capacity building and patient education and information. Maybe a couple of additions specifically on the section on task shifting to patients, because I think you mentioned quite a lot of these things, but for the sake of completeness, maybe you could actually expand a bit more. So for example, there's a range of chronic diseases that can be treated at home and are increasingly being treated at home. So these are definitely being enabled by things such as digital health and also the fact that patients are being increasingly more informed to take care of their conditions. However, as you rightly also pointed out in the presentation, there's a number of barriers to that uptake and to shifting more tasks towards the patient. So there's still a lot of things that could be done around education, not only for patients, but also around for healthcare professionals, nurses, and doctors. For example, for chronic kidney disease, oftentimes doctors maybe are not aware of home treatments, or maybe do not prescribe, or maybe even patients are not aware of this option that could actually be better suited to their lifestyle and have similar outcomes for them. And also you pointed out in your presentation to financial disincentive. So I think this is a good point that should be further expanded upon. Oftentimes we don't think of other outpatient care settings because there's financial incentives to actually provide care in the hospital or in the traditional settings, let's say. And then related to this point, but more towards the section on shifting toward care towards from people towards machines. Again, fully agree with the points that you raised, but there, although you did mention it in your presentation, you focused a lot on machines, whereas digitalization and digital health is much broader. So I think for the sake of completeness, again, there's quite a lot of scope to give concrete examples on how software or different digital tools can enhance care in the future. So, you know, there's examples like telemedicine or remote patient monitoring and looking at concrete diseases and how that can enable things. I think that could definitely be an addition to the draft opinion. And then finally, one question to the panel. So there is another opinion on value-based healthcare that is out almost at the same time. And having read through both, we see quite a lot of overlap in between them. So I was wondering if there are any plans to integrate them further or to actually make some more robust recommendations looking at both opinions at the same time. Thank you. Thank you again for the report.
Okay, so now thanks for those comments. I think I heard quite a bit about task shifting to the patient, which I think is we cover it in the opinion. I mean, we heard some additional examples, so we can think whether we might want to integrate. And I don't know, Martin, would you like to?
Well, I see a gentleman down there shaking his head about whether we captured it all. Can I just make absolutely clear, if anyone has high-quality evidence and peer-reviewed journals that we have missed, send it to us. We are perfectly open to including it. Sorry, somebody wanted to.
Yeah.
That's not you know, we can't, and we don't claim to have covered everything but we've been pretty comprehensive, and we've taken a fairly rigorous approach to systematic reviews and so on.
We have patient organizations that help patients 24/7, coaching them through the healthcare system, assisting them with any question they have from a medical, non-medical perspective. And that is something that is not in peer-reviewed journals. This is the practice of every day. There is a tremendous shift going on and a high demand from patients to have more clarity on what needs to be done. We help patients with the questions they need to ask to their doctors. We help patients with the non-medical aspects. We help patients to guide them to psycho-oncologists, to social workers, etc. Without us, many patients would be lost in the system, would not have the adequate care, and would have late care. So don't under-evaluate, please, the role of patient organizations moving forward. And I think it is absolutely critical to recognize the role of patient organizations and not only the self-management of individual patients. I want you to recognize that. We are not in peer-reviewed journals. There's a reality beyond peer-reviewed journals. There's a reality of everyday effort by hundreds of volunteers in every country to make life better for patients. Please recognize that. That is my question.
Well, I will answer it quite explicitly. We are an expert panel that works on the basis of evidence. If we have the evidence, we are very happy to do it. But assertion is not evidence, I'm afraid.
Do you ignore that patient organizations are active in every country?
No, but the fact that, yes, I agree. I mean, so if the question is, do patient organizations exist across Europe? That's an empirical question. The answer is yes. Do they make a difference? You say that they do. I suspect that they probably do. Do I have evidence that that's the case? I don't.
Well, then make a recommendation that it's high time to do research on that and deliver evidence. We are the only ones with the energy to move things forward. We are the only ones with a sense of urgency to make things happen. We are the drivers behind screening programs in Europe, because if we don't do
Screening for what?
Screening for colorectal cancer.
Well, no, hold on. The European Commission has issued guidelines on colorectal cancer. No, we've actually researched that.
Don't make me laugh. This is, in 2003, every single member state said they would have national colorectal cancer screening programs for patients from 50 to 74. Only 3 countries do it today. Only 3. I can give you the evidence of that. So please don't ignore patient organizations. Okay. That is my question.
Okay, just have a look at our publications from the European Union-funded Utopia project, which looks at the barriers to screening in Europe. We've looked at it in great detail. I take your point that there are problems, but there are many problems that are not. It's a more complicated.
If every country did what the Netherlands did, 130,000 colorectal cancer patients would not die every year in the European Union. 130,000. And there are countries like the UK who are fiddling with the tests because they don't have the capacity for colonoscopy.
Okay, so
I have moral outrage because there's a lack of urgency. There's no sense of urgency, and there's a lot of discussion about,
fair enough,
abstract things, and nobody is moving forward. Everybody is hiding behind paper-reviewed or peer-reviewed journals.
So
there's a reality
like to
on
say
the floor.
Something, and then maybe we could move on to the next, just to give space to everyone to contribute.
I think that
to
we all see kind of a gold line that goes from all the comments, that there are changing roles of the stakeholders that are involved in health systems as such. The changing roles have to be evidence-based. The European Patient Forum has done several studies. We have the evidence on self-care, self-prevention, on issues like the efficacy of screening programs as opposed to targeted provision of care based on digital data, as the Baxter colleague said, on genetic information, for example, rather than screening. These are all things that we are considering, but when we are making an opinion, we have to base it on evidence. I do agree that there are changing roles of the involved entities in health systems, and the evidence is being produced in projects. Most of those projects have been co-financed by the European Commission when it comes to self-care, self-prevention, and patient organization. Ask the EPF.
We're absolutely not ignoring you, and I really want to make sure we're clear on that. We have listened to you. We are not ignoring you by any stretch of the imagination, and we've given you plenty of time to talk. So please don't say we're ignoring you.
There's a change in role for patient organizations. Mention it in your report.
Okay, let me check if there are other questions from other people who. So is there people? Okay, yeah. So if you could also flag, yeah, please go on. Yeah, no, you're on.
Yeah, thank you very much. My name is Jan Wagenaar. I'm the Vice President of the Chiropractic Union in Europe, representing the chiropractors in Europe. Well, thank you for your report. I have a few comments I would like to make, or some additions actually, and I might need some help on that, because I sent you this weekend my comments with the well, the references, as you call it, if you
sure.
would like to have. And they basically go, they are about the non-communicable diseases, especially the musculoskeletal part of it, which is no mention in the report. And basically there's a lot of EU reports which is not mentioned. A non-fatal disease, but a growing burden on society, at least as I am a trained physiotherapist and chiropractor. And I see a growing number of patients with arthrosis and musculoskeletal conditions. There's no mention about it, so I was hoping to make some comments and basically some additions to the draft you made. There is together with the growing musculoskeletal conditions, there's, and it's mentioned before, people, there are less GPs, huisartsen we call them in Holland, less nurses, and 30% of the GPs see, or maybe GPs see 30% of their patients with musculoskeletal problems. And in the England, which is it's a growing problem, NHS is now changing or using first contact practitioners, FCPs, basically physiotherapists which are trained as first contact practitioners, and chiropractors, and it seems to be working really well. This is I mentioned with the references as well. Norway, Denmark are using chiropractors as non-first contact practitioners, and that seems to save money. I don't know, it's not...
So it would be useful when you comment if you could also reflect on how this relates to task shifting. I mean, that's what you're
task
commenting.
Shifting is basically...
So if you could elaborate on how that
the
fits.
Task shifting is basically comes down to GPs who are too busy, and there's a shortage of GPs, basically have their musculoskeletal patients being seen by first contact practitioners, being chiropractors and physiotherapists.
So basically, what we need to do is you're sending us the references. We need to include a section on shifting between GPs and chiropractors.
I send them to you, and
well, I haven't got them yet, but I'm sure we can do that. That's not a problem. We'll look at the evidence and we'll include it.
And I think that's most of it. Yeah.
Good.
Thank you.
No problem.
Okay.
And as I say, this is a general plea that if there's something that we have left out where there is clear evidence, we can't cover everything, but if there's clear evidence, send it to us and we can look at it and incorporate it if appropriate.
Yeah, I mean,
well, next week, I think. I mean, if you've got the evidence now, send it to us. It won't take more than a few days.
Okay, so I think that there is a question down there. So let's,
related to that, I had a very practical question. Where can we send comments in writing, and what is the deadline? Because we haven't actually received any information on that. Thank you.
Okay, I think we'll get back to this point at the very end. So let's carry on with the other questions on the report. Are there? Yeah, there's one there. Yeah.
I'm Maciej Rodzinka from Mental Health Europe. We are the largest organization representing users, patients, service providers, researchers working in mental health field. I'm very pleased with the general message of the report because for mental health it's extremely important to work as an integrated team and to share information among each other. But I would like to just point to one issue that I see missing from the report, and I totally agree with you that you cannot cover everything, but I just want to make sure that this is included because there is existing evidence on peer workers In mental health, it's especially important.
Yeah, good point.
Because patients are not only working and are not only able to self-manage, but are also able to provide help for others experiencing the same.
Again, if you can just send us something on that, it's a
I
good
have
point.
evidence. Yeah, exactly. I can
okay.
send it to you, so just to be sure that your workers are.
Yeah, point taken.
Whatever.
Fair point.
Thank you.
Okay, so other.
I mean, the challenge in doing the systematic reviews that we did is you don't always get everything, but that's why we have these hearings. So again, with both chiropractors and peer workers, please just send them in.
Okay, other comments? Yeah, there is one over there, please.
Good morning, I'm Shahad Adash from the Standing Committee of European Doctors, CPME. Thank you very much for today's event and also for the draft report, which brought together a huge amount of evidence. I have a question looking more into the methodology or presentation of the evidence in the report. You say that you categorize it now from, let's say, point A to point B, where the task was shifted from where to whom, and enablers and barriers are kind of separated a little bit from that. I was wondering, because personally I would find it very interesting to see in the different instances that you discover in the reviews whether it's possible to go into more detail, for example, at what level decisions were taken to carry out task shifting, at what kind of conditions accompanied it. Sometimes it said there was additional training, but it would be interesting, for example, to see if there was also changes to reimbursement systems, possibly legal changes. We've already spoken about liability. If that, from point of view of methodology, would have been possible, because I think it would be interesting information to have.
I totally agree that it would be absolutely fascinating, and if you can find a PhD student to extract the information from the papers, we would be very happy to see you do that. But remember, this is an opinion undertaken by a panel. It is not a PhD, it's not doctoral research. I think you're asking something which goes way, way, way beyond what we have the capacity to do. But having found the articles, then the next step is for somebody else to do it. I think you've got to be realistic about what is possible. We have produced an exceptionally detailed report with an awful lot of references and done a lot of work to pull everything together. But if we're going to then go on to the next stage and do further detailed analysis, I think the challenge you're going to find is that in most of the papers, it's going to be quite difficult to extract that, because we've done similar exercises in research as individuals in other areas, and often those things are not actually captured.
Any other comments? Yeah?
I just have to make a final. If you do systematic reviews and if you confine only to medical publications,
we haven't, but
no, but then you won't find. We're talking about innovation processes that are really shifting by the month at the moment. So do a systematic review of evidence base in the background, which will rule out. I'm just saying, I have never criticized that this is a good, I think it's a good, but it's a perspective. This is one perspective. I just want the recognition of that.
And I think we have actually accepted, we say very clearly, there are a whole series of literatures of scholarship that have an interest in this particular area, like, as I say, the theory of professions, like the literature on power, like the literature on markets, hierarchies and networks, all of which could easily have been put into this. But the danger is that we then create an encyclopedia of organizational theory or something like that. And we do definitely look in our work far beyond the medical literature. You just need to look at what we write in other areas. In fact, some of us are sometimes accused of going too far beyond the medical literature.
Okay, so if there are no further comments, so I would like to start to wrap up. So I think we have heard quite a lot of comments. We had the lively debates on different topics. I think Ales is now writing up the deadline for providing comments, which is the 10th of June. And this is the email to which to provide the comments, which I think you can also find on our website. So now I'm just going to ask the members of the panel if they have any final words. Martin, do you have any final words?
No, I think I've probably said enough.
Yeah, Ales, is that anything you would like to say?
Yes, I would like to thank for all the comments. We will try to incorporate them if they are underlined with literature that we can use as evidence-based literature, obviously. I'm sorry, this is the address. I know it's rather tight, the deadline for the 10th, but we have a meeting on the 26th, which is the expert panel meeting, and on the 27th we have a work group meeting, so that's where we will try to start finalizing this document so that it could be published soon afterwards. So that is also the reason why the deadline is so tight.
Yeah.
What was it? 26th?
No, the deadline for you, please, to provide us with
Comments?
the underlying literature and the comments is the 10th, but we will have the meeting on the 26th and 27th in order to be able to finalize it. But before, we have to work together to incorporate it so that we don't lose the line of thought of the whole document as such. We are fully aware of the changing roles, so at the same time, there are changing roles. Doctors used to be the ones that knew, so they provided information. Today, they are the information brokers, because everyone can get the information online. Same patient communities used to have a different function. They would provide emotional support. Today, they provide physical recommendations and guidance to the members of such a community. Physiotherapists, chiropractors, the industry as such, and digitalization, these are all issues coming into play. We are limited to the number of pages in the reports, but we will include all of your extremely valuable observations. That is the reason why this meeting was done, and we want to thank you very much for this.
Yeah. Thank you. Thank you for your comments. Yeah.
And you're free to go.
Well, that's fair enough, but we will review anything that is there that we can judge the... No, well, no, of course you exist. I mean, you exist, you're here. I mean, that's not... Well, we can...